Hi everyone, my name is Kristen McCarter. I'm a psychologist and PhD candidate at the University of Newcastle, and I'm presenting today on behalf of Ben Britton and the rest of the Eating as Treatment or EAT research team. So our trial was conducted in patients with head and neck cancer, and malnutrition is a common and big problem in head and neck cancer due to the location of the malignancy as well as the area in which the radiotherapy is delivered. And malnutrition is associated with poorer outcomes in radiotherapy, including mortality. In terms of risk factors, tobacco and alcohol use are the two most common risk factors, with HPV also becoming a significant risk factor. It's more common in males than females, and it's most common in people over 50. So just before I talk about the EAT trial, the pilot trial for this was called Heads Up, and it was basically a feasibility and effectiveness pilot trial to look at the effectiveness of a psychological intervention delivered by a psychologist to improve nutritional status, depression and mortality in patients with head and neck cancer undergoing radiotherapy. And subgroup analysis in this pilot trial among patients that are at greatest nutritional risk, which are those with cancers of the oral cavity, pharynx and larynx, revealed a potentially clinically important reduction on the PGSGA, or the patient-generated subjective global assessment, which is considered the gold standard oncology nutrition tool. And it also revealed lower mortality in favour of the intervention condition. And so because of the potential benefits in nutritional status and mortality, we refined the psychological intervention to some key principles of motivational interviewing and cognitive behavioural therapy that could be delivered by radiotherapy dietitians alongside their standard dietetic consultations, and that became the EAT trial that I'm presenting today. So just a little bit about the study design for those of you that aren't familiar with a stepped wedge design. The trial used a stepped wedge cluster randomised control trial, and in that design, each site or hospital in our study starts in the control condition and acts as its own control, and then moves to intervention condition in a randomised order. And a stepped wedge cluster randomised control trial has the same level of evidence as a parallel cluster randomised control trial. It just means that you can use fewer sites. And so the content of the EAT intervention, as I said, is basically a distillation of behaviour change strategies from motivational interviewing and cognitive behaviour therapy. But importantly, it was designed specifically for radiotherapy dietitians to deliver alongside their standard dietetic consultations and targeted around behaviours to do with nutrition. And so although the training that we delivered to dietitians was standardised, the EAT intervention is mostly a style of interaction and uses sort of simply worded guided principles for the dietitians to use in their standard practice. Our intervention was also aligned with Australian developed evidence-based practice guidelines for the nutritional management of head and neck cancer patients. In terms of our training, when a hospital moved from control to intervention, our research team travelled to the site and delivered training over a 2-day workshop. The research team also then followed dietitians into their standard consultations for 1 day after this to help them implement the skills that they'd learnt and problem solve any clinical concerns. The research team also returned 2 months after that initial training to deliver booster training and also again help problem solve any concerns and any practice or systems change problems that might have arisen. And during the intervention phase, dietitians also had regular supervision with one of the research team who was a clinical psychologist. Additionally to this, during the intervention phase, sites received a range of supportive evidence-based practice change strategies to help the dietitians implement the EAT intervention specific skills, but also improve their provision of care according to those evidence-based guidelines. And the recommendations that we targeted from those guidelines looked at regular contact with dietitians during and after radiotherapy, the dietitian's use of a validated nutritional assessment tool, which was that PGSGA that I talked about before, as well as distress screening and referral. And so in terms of the evidence-based practice change strategies that we implemented, we solicited the support and endorsement of executive staff at both the radiotherapy and dietetic departments of each site prior to delivering the EAT intervention, and asked that they obviously would support the intervention throughout that phase. We also delivered training, as I just outlined. We conducted academic detailing, which included that extra day following the 2-day training workshop to help the dietitians implement what they'd learnt. We provided tools and resources, so that included things like the distress screening tool as well as the nutritional assessment tool. We also worked to create systems, so to facilitate patient attendance for dietetic appointments and position nutrition as an important part of treatment, just as is radiotherapy. We asked the sites to schedule dietetic appointments time adjacent to radiotherapy appointments as well. And prompts were placed in the medical records of intervention patients to remind the dietitians to use those guides that we had trained them in, and also to implement nutrition plans, which was a key component of the cognitive behavioural therapy side of the intervention. And finally, performance audit and feedback. So the senior dietitian and behavioural expert from the research team had regular phone meetings with the head of the dietetic department at each site about every 3 months to give them feedback on how they were performing against agreed benchmarks that we had set in the previous meeting, specific to the EAT intervention skills and the guideline recommendations. As well, during those meetings, we would problem solve any sort of systems or practice change issues that might have arisen. And so in terms of our outcome measures, our primary outcome was the PGSGA, which is considered, as I said, the gold standard in oncology nutrition. It consists of a self-report questionnaire as well as a clinical assessment, and higher scores on the PGSGA indicate a higher risk of malnutrition. For intervention fidelity for our dietitians, they were required to audio record their sessions, and a sample of those were rated for fidelity to the intervention. To measure performance of the sites and dietitians against the best practice guideline recommendations, we used those audio recordings, and we also conducted regular medical chart record audits as well. So on to the results. We recruited 307 patients with head and neck cancer across our 4 sites. The mean age was 58, and 21% of the sample were women, which is relatively representative of the head and neck cancer population. 13% of the patients self-reported at baseline that they were current smokers. However, CO verification confirmed that potentially more like 34% were currently smoking. And about 1/3 of the sample were hazardously drinking at baseline, according to the audit. In terms of the rates of tumour sites and stages, they were relatively representative of the head and neck cancer population again. So for our primary outcome of nutritional status as measured by the PGSGA, we found that participants in the intervention group had significantly lower or better scores on the PGSGA than those in the control group at the end of radiotherapy. Also, those in the intervention group were significantly more likely to be in the well-nourished category of that tool than those in the control group. And control patients lost a significantly higher percent of their baseline weight than intervention patients. In terms of the dietitians' EAT intervention-specific skills for the fidelity outcomes, the most marked change we saw was in dietitian skills specific to something that we called the Eat to Live conversation, and that was something that we trained dietitians and asked them to deliver during week 5 of radiotherapy, which is when the radiotherapy symptoms really start to build up and come on board, and it's very difficult for patients to eat. So despite the evidence that we have that supports the link between radiotherapy outcomes and malnutrition, prior to training, dietitians really didn't explore this fundamental motivation for patients of survival. And post our training, we saw about 60% of dietitians delivering that Eat to Live conversation in week 5. We also saw a significant increase in dietitians developing the written nutritional planner and collaboratively reviewing that nutrition plan. As you can see, there's still a lot of room for improvement with that one. And we also saw a significant increase in dietitians' use of general behaviour change counselling skills as well. So in terms of performance according to the evidence-based guidelines, when we look at the provision of care provided by the dietitians, the odds of implementation of 4 of the 6 guideline recommendations were significantly improved, suggesting that our practice change strategies were effective in improving dietitian provision of care according to those guidelines. And the greatest improvements that we found were for distress screening and referral. So despite distress screening and referral being recommended in the evidence-based nutritional guidelines for head and neck cancer patients, that wasn't something that was being delivered at all in any of the sites using any tool. And so that was obviously the most marked increase that you can see there post our training. And so just some concluding thoughts. The trial demonstrated significant benefits of the EAT intervention in both patient and clinician-generated scores of nutrition, as well as for percentage weight loss. After training, the dietitians demonstrated greater application of those EAT intervention-specific skills, as well as behaviour change counselling skills generally. Importantly, application of the EAT intervention was not associated with a significant increase in session duration, so it's extremely feasible for delivery in busy clinic settings. We improved adherence to best practice guidelines, and we believe that the EAT intervention represents a useful model for increasing the routine application of important but often underutilised evidence-based motivational and behavioural strategies by oncology dietitians. Thank you. That's the protocol paper, if anyone's interested.